Welcome to this Roundtable, Migrant Health in the Pandemic. My name is Esperanza Diaz, and I'm professor at the University of Bergen and leader of the Pandemic Centre, which is hosting this event together with the Center on Law and Social Transformation. Next. May have changed the game, but inequality is still the key player. This is something we're going to try to address partly today. Because the pandemic is indeed a magnifier of many injustices and challenges we had from before. Specifically in terms of migrants, we don't have data about many countries, but the data we have is that migrants are overrepresented among those who have the disease and those who have been hospitalized, and probably among those who have died because of the disease. Particularly in Norway, where we have quite good data, 35% of those who are positive throughout the pandemic are migrants, and about 50% of those who have been hospitalized are migrants. When we know that we have a migrant population of approximately 17% in the country, we can see that these numbers are completely out of proportion. So the Pandemic Centre, which I represent here today at the University of Bergen, is an interdisciplinary center aiming to address these complex situations, causes and effects that interlink health with many other social issues. And today with us, we have Camila Gianella, Executive Director at the University Católica de Peru and researcher at the Kristin Institute in Bergen, who will be with us in the internet throughout digitally. And we have here together with me, Kristin Sandvik, who is research professor in humanitarian studies at PRIO and professor at the Faculty of Law in Oslo. What we're going to do is to ask them to talk about two different subjects. And afterwards, we will have time for questions and comments from the public, both here and out there in the world. So please, I will invite now Camila to talk about Venezuelans in Peru, necessary but excluded. The floor is yours, Camila.
Thank you, Esperanza. And it's really nice to join this panel, even from Lima. Well, as many of you can know or are aware, Peru is one of the countries that is among the most affected countries by COVID in terms of deaths, in terms of children that have lost their primary caregivers. And before the pandemic arrived, we already have a humanitarian situation with the Venezuelan migrants that has been, there's a big influx of Venezuelan migrants since 2018, come the big numbers of Venezuelan. 2016, we flexibilized the regulations around migration. So in one point was the political decision was to allow these migrants to come, also as a political sign against the Maduro regime. But then, because of the big number of people that was coming to the country, coming from Colombia, that have received most of them, and Ecuador, they were sending them to Peru. We started to change some of the regulation, making this tougher, the conditions from Venezuela here, and was already a lot of xenophobia against Venezuelans in Peru. So the media was putting them as criminals, to most of them, and in general, the state was already failing to support this population that was already in a really bad situation across the country. So when the COVID come with a lot of challenges for the Peruvian health system and in general for the Peruvian welfare system. And the pandemic showed that we didn't have a welfare system. So with the 70% of the population in informal work, was really difficult to people to stay at home. And if we are speaking about Venezuelans, almost 100% Venezuelans are in informal work. For them was really tough to stay at home during the general lockdown. Then things come, and then Venezuelans, because they were without a job, they started in some cities like Lima to pick up the voice of the dead people at the houses. So they were starting to look for jobs. And in one moment of the pandemic, around May, June of last year, this was put as a heroic, in a way, change some of the public opinion view around Venezuelans. The state has failed, and despite of this, the state failed to put Venezuelans as the recipients of any kind of economic support, because they are not citizens of Peruvian citizens or with a permanent resident. So they have failed to put them in the list, and they have not been receiving the cash transfers or nothing. We don't have data that specify how many Venezuelans have died as a consequence of the COVID. We don't have information about how many children, Venezuelans, migrant children, have lost their primary caregivers. So there's not statistics on that. And right now, we don't know how many of them has been vaccinated. So we are, despite of the recommendation from UN agencies and from the Venezuelan organizations that are here in place, there has not been any capacity to identify them as a vulnerable group in the statistics and to see how is the situation after the COVID, during the pandemic that is ongoing. So we are in this moment that flexibilizing some of the measures, waiting for a new increase of the cases because we have the Delta variant here, but still the state has failed to make any policy targeting specific the Venezuelan population here, and they are still in a dramatic situation, and we are not able to provide any assistance. And I will put it there right now.
Thank you very much, Camila. Kristin, you are with us now, and we'll talk about vaccination and social justice. Please.
Thank you. If I can just have a short comment to what Camila said. You know, during this week, we've been discussing the problems with the digital transformation and how collecting data creates targets, it creates the potential for harm. But here we also clearly see how lack of digitization, lack of statistics, lack of data, it's not only problems in the current moment, but it's only if you don't know how many children have been orphaned because their parents don't have official status, how can you possibly provide aid, for example? So I think it's pause for thought for all of us who are technology critics. You know, what can digital tools could they have done here? And also, I just have to say, I worked on this in the beginning in Norway. I've been working fairly actively on the Norwegian COVID-19 response. And you know, when you looked at all pandemic plans in Norway, there wasn't anything about immigrants, there wasn't anything about strategies, there wasn't anything about specific areas. And you know this, that where you need to intervene. So I had a friend who for weeks would say there's no information at Grønland, which is a part of Oslo, where you have, you know, very dense immigrant population. There is no information, except for in the region and fairly convoluted. It doesn't reach the channels. So it wasn't like, this shouldn't have been a surprise. And it seemed to have been a surprise. And still after this, you know, the government finally turned around and gave money to Norwegian organizations. And so there was all these things that, you know, basically all the things that was wrong in the book were sort of done the first months of the Norwegian pandemic. And things have worked out quite well in Norway. I mean, the statistics don't look good, but we know that we have some mortality, for example. But I do think there's a lot to learn here. And then I think it's a discussion we need to continue. And as Camila shows, it's absolutely legal.
Well, come
But
back to this.
we'll come back to this, but I'll get to the vaccines. So my background is on rights-based approaches to health. I worked in HIV/AIDS, Ebola, and then now COVID-19 in the humanitarian context. And so my concern starting late last year was, what about refugee hesitancy with respect to vaccination? And the first 3, 4 months, 5 months, I tried to discuss this with anyone. They would just look blankly at me and say, I can't see that's a problem because the West is hoarding vaccines. No one is getting vaccinated. You know, it's extremely unfair and this is what we should care about. And that remains true, right? I mean, the vaccine nationalism and the global injustice is absolutely terrible. But if we think more carefully about this specific topic of what does it mean in the context of international legal protection and mandatory vaccination schemes, I think it's something that's increasingly being something we have to think about as workplaces, airline companies, global companies want their staff to be vaccinated, and countries are concerned about the Delta variety, for example. So we thought that COVID was going to pass in waves, but now we see that new strains, you know, work differently with vaccinated populations. So the question is, can you mandate vaccinations for refugees and asylum seekers? And you know, on what grounds? How would a vaccination program what would it need to look like? So this is not unprecedented in the humanitarian field. So there are examples of populations being made to take, polio vaccination in exchange for food aid. But that's something different than international legal protection, which is regulated by international law. So essentially, this becomes a trade-off between individual choice and bodily integrity and national security interests and the obligation of the state to protect its own population against health rights and health threats. So these questions are already there in international law and international human rights law. But I think they're interesting to discuss. We know that there have been very unfortunate vaccine programs in the past. There have been unethical experimentation on populations. But we also know that global health outreach has been under extremely hard strain the last decade or so, with health workers being killed, being targeted by armed actors who say that they're there to, spread kind of a Western virus, et cetera, et cetera. So in terms of health work in danger, this is really part of that problem. So my this scenario I developed was of what would, how can you create a mandatory vaccination program at the borders, and for whom, and what does it take, and is it all legal? And I think one sort of starting point when we think about this is that we don't assume that people who don't want to get vaccinated are stupid. So in the West, some of us come from countries where we have large anti-vax constituencies. If you're German, you look at the Querdenker and you think, oh my God. In the US, people who don't want to get vaccinated are a real health risk for the rest of the population. But you're not necessarily stupid if you don't want to get the shots. I mean, you can come from a group that has been subjected to humanitarian interventions in terms of NGOs, bad projects, aid worker abuse for decades, right? Some populations have very low trust vis-a-vis the international community. So you might be the nicest aid worker in the world, but I'm not going to trust you because you've been here more or less for a decade or two, and you only did violence, and sometimes you came with soldiers, and you never kept your promise, and your services were bad. So I think there has to be this recognition that there are good reasons to be suspicious. And then, of course, people have religious beliefs sometimes that said, being vaccinated is not in, line with Sharia or with, in the southern Norway now, I read that the preacher had been threatened that, the vaccine was Antichrist. This happens across the board, right? And then he was promoting Satan to the region Bible Belt. So we should just be humble in terms of where ideas come from, and that there's misinformation, there is sort of political disinformation, but just don't assume that people are ignorant. And then also, if you're going to have a mandatory vaccination scheme, you know, this idea about respect, about enough information, and then we're back to health information. The fact that if there are health problems, you have to provide people compensation. So to have a legally mandatory vaccination program, it needs to be very comprehensive. And in terms of investments in refugee health, that's very often not the case. So, and with refugee resettlement, we already have established that before you board that train with the IOM, you have to go through a health program, which might require basic immunization, for example. But it's a real sort of, people refusing to get vaccinated are a real threat to global health, and it needs to be taken seriously. But in terms of the little sort of microfield of refugee protection, I think there are discussions we need to have, and we need to look at the pros and cons, but also at how we sort of solve this problem without resorting to sort of assumptions about people's intelligence or rationality. But I do think that this discussion is going to look very different 6 months from now. So once the vaccines really become available, we can start discussing hard cases. Just to finish off, there was a recent example of a group of religious Burundians returning from Rwanda because they didn't want to get registered biometrically. They thought that was against their religion. So they made the decision to turn around. So we see that groups make informed and high-cost decisions based on their beliefs. But I think ideally, it would be a scientifically based decision to refuse vaccination.
Thank you very much. I will just open for questions here from the public, and you can also post your questions through the internet. In the meantime, some kind of reflections, because we have listened to two different small parts of the whole thing, because it is a very big story in a very big field, and it's worth saying that it's in a way completely impossible to talk about migrants, because migrants is not a group. It's a lot of different groups, and there are refugees, but also within refugees are the differences. So we are trying to generalize things when it should be particularized. But anyhow, we try to do it as well as we can. And it's been called this pandemic a endemic pandemic because there's a lot of complexity, because it's not always going to be, but all parts linking together. This is what we're going to try to address here. So no easy answers. We're not going to give the whole answers for this, but just to lift up some of these complexities. Just to begin with, we have heard Camila talk about xenophobia. You have talked about trust. We have talked a little bit about information and misinformation. One of the things this pandemic has lifted up is what is really specific for migrants and what is for everybody else. So what are the determinants which are specific for migrants? Because you can see yesterday in the journal here in Bergen, there was a healthcare professional, Norwegian, who said, I do not want to take the vaccine. And there was a lot of bad words against that person. And she was not a refugee, right? So what is specific from migrants or refugees and what is not? Camila, if you can take it from the Venezuelan point of view in Peru, is there anything of what is happening there that you could say is specific because they are migrants of what is going on? And then I will pose the same question to you when it comes to vaccination and hesitancy.
But in the case of the Venezuelan here, they have been using most of them have been using the public services, no? And in the Peruvian public services, health services, there is this culture of, there is an institutional culture that doesn't like people that complain or ask for things. And Venezuelans are a different culture. They ask, they demand for the rights, for the things that they think that they have the right to. And that does, and people don't necessarily like that, health workers. So it was already a lot of defense from the health workers towards the Venezuelans here. I think that there is a bad understanding of Peruvian authorities saying, yeah, because they speak Spanish also, then we are the same culture and we will not have any problem. Then there is another point that they have different needs, health needs. I have been supporting work of a colleague that she's doing things on maternal health in Venezuelans in Lima. And there is a thing of they use different methods and that was already difficult for the health system to approach to them. And so there were already needs that they were not covered by the Peruvian health system. In the vaccination, this is, most of them are young, so they has been the last ones that they are going to access to vaccines. But they are all the time in the streets. So we need to target them and to try to get them vaccinated. We don't have that, and they are rejecting the vaccines. We don't have that information because we don't have that information for the whole population and we don't have that from the people from the migrants from Venezuela. But what we say is that at the beginning, one point they were saying that only to the residents they were going to get the vaccines, and this was a discussion last year that the same happened in Colombia. And this was rejected by most of the public health people that say, if we don't vaccinate the whole population, this is not going to work. So that restriction of the legal residence was taken out, and you just go to the vaccination center to vaccinate. In the case of Peru, they were at the beginning trying to make by list, like you have your ID, and then you come, there is an appointment, but that was also not working for Peruvians, because what the pandemic have shown is that we don't have an information system. This is a joke in Peru. We don't have that. We don't have the information system for Peruvians, for citizens, and we don't have nothing from Venezuelans. So now we are having this, it's called vacunatones. So there is a day that you can just go drop to the vaccination center and you just get your vaccine. If you have an identification that say that you are in the age group, independently of your residence. So that is good because we are not making any administrative barrier to the issue of vaccination to the Venezuelan refugees and to the migrants, but still we don't have the data that tell you if there is any special need of information from this group of the population. The communication has been the weaker part of the vaccination here, and so yeah, we have not developed any kind of communication or education strategy that is targeting this population.
Thank you very much. We will come back to that of the data because this is the main issue. But if we come back to you, Kristin, with the question, what do you think is specific about this field you're working specifically in, because people being migrants or refugees?
So in a way, there isn't any specific as such, right? So the state has a certain margin of discretion, in proportional in a democratic society, necessary and proportional. So you could imagine more discussions about domestic mandatory vaccination schemes in countries with low vaccination rates. We see that this happens in some private sectors in other countries, like in the US. And I think that's a discussion we're going to see more of. With healthcare workers, I think it's a legitimate question as to whether, if you want to work in healthcare, that's the duty of care. You can't sort of do no harm. But in a specific case of seeking asylum and refugee protection, and obviously, this is presented through the prism of a very sort of clean scenario of somebody showing up and asking a frontline worker to deal with a protection claim. The state, I believe the state might legitimately require people to agree to vaccinations before entering that process, before engaging with individuals. And of course, we've learned over the last year and a half that in bureaucratic procedures, you can have 2 meters difference and you can have your full gear on you, and there can be protection. But this is essentially, it's a question of what the state can ask for somebody who's entering. And you know, we've seen states, even Australia, barring their own citizens returning, right? So it's clear that states can take pretty extreme measures, also with respect to their own citizens. But the question is this a good idea? You know, the moralist in me wants everybody to eat like no meat and take push-ups and stop smoking and you know, do all these kind of things. But is it effective for people's lifespan and enjoyment? And the same question is can you really effectively force people to take vaccines? Is it a good idea? What is going to happen to other immunization programs that are much more important if we make this an exercise of force in a context where people already have thin trust, right? So this is where we're back to information, decency, respect. If people have side effects, you know, give them compensation, make sure they're dealt with. Treat people as human beings. So everything, but you know, we're not looking at sort of holding down people and sticking them in the arm. But you know, if you're told that you can't proceed with your claim until everyone in your group has taken the shot, that's also force for somebody fleeing their life. And I think we're going to see interesting questions pop up now. So obviously the Western countries are trying to evacuate Afghans as well. I just read that the UK is placing 2,000 Afghans in Uganda. And they were going to be tested and sent to quarantine hotel. But the Western countries aren't taking these refugees back home. You're sort of making agreements with third countries to accept populations. But I do think that vaccination issues are going to pop up here. Also because people carry different strains. And you know, this is one of my colleagues here yesterday say, I wonder about going to field work in a population that hasn't been vaccinated, because even though I might carry a strain. So I think this is endemic, right? It's going to stay, but essentially, you know, we should try everything but force, but we still need to think about how to regulate.
So when I listen to you, both of you, I listened something about culture that Camila talked about, a different culture, different way of asking things, and you're talking more, as I understand it, as a more higher vulnerability. So the situation might be the same, but the consequences are completely different for some people than others. And you talked previously as well about humility, and I'm wondering a little bit if we have enough cultural humility at all to understand when it's going on, when we see the situation from others' situations, right? And it might be in the global south, but it might be here in Norway and in Europe with the migrants we don't understand. So in the fields you're studying, how is culture situated to explain these differences, and how do you address this issue of culture, migrant culture, refugee culture, to explain or to address the different issues that you take up? We can begin again with Camila. Next time you will begin.
I think here in the Peruvian context, before the influx of Venezuela camp, culture was used as to portray it as a barrier, no? So if you are not Occidental thinking as the health system wants you to think, then this is a barrier. And that is not thinking in all the other problems that people face to go to the health facilities. So with indigenous people, it has been portrayed as cultural barriers, no? And you say, well, what are the cultural barriers, and why the cultural barriers only come from the people that are coming to the health centers, and you don't see the cultural barriers that you have as a health provider or the health system have towards different ways to think health or to understand health. So most of the time it's seen as a barrier, no? So then you can say, yeah, the Venezuelans have a cultural barrier to have the second shot of the vaccine, for example, no? And probably that is not the case. It's just that they are in the move, you know, and you need to understand that to be more flexible. But in general, we have been not good in the past with this. We have not been good to try to adapt the health system to the need from this population that is in the move within the country. So if they get the insurance in one city, they can only go to that city, and that doesn't have any sense for Peruvians and also for Venezuelans. But here it has been portrayed as a barrier, and it's just everyone say, okay, this is a cultural barrier, and it's their problem, and they have to solve it, and that is not in general the situation. And also what Kristin was saying is this making mandatory used to be to the more vulnerable and the poor, no? Even for teachers in the school, for example, no? So they are speaking to make, this is going to be mandatory for teachers in the school, for the public schools. But if you work in a private school, that doesn't going to happen like that. But no, we cannot ask them. So then we need to make this more transparent. This is going to be mandatory only for the poor, and the rest can go just around this, or this is going to be for everyone, and it will be a better way to address it. No?
And I think that with mandatory, when you look at the history of vaccination, whenever it's mandatory, it's against people who are more marginalized or working class. And whenever you find vaccine skepticism, maybe except for pockets in the global north. We have them in Prenzlauer Berg in Berlin. There is one who refused vaccination, based on certain esoteric beliefs. Usually it's used for governing purposes, along with a toolbox of other sort of interventions to govern people. But I think, the pandemic for cultural anthropologists it's a fascinating thing, right? We all have culture. And I think for Norwegians, it's been shocking that Sweden had such a different approach. I think that's probably been culturally the most shocking thing about the pandemic. But also, I think helpfully, when people live in small apartments and can't have distance, and your mom is a nurse and your dad is a bus driver, they are frontline workers. They're going to go to work. And when their parent calls from Pakistan, they have to go, right? So this is less culture than just sort of socioeconomic factors. And I hope that we have learned, a little bit about using the cultural lens less, and just look at sort of people's life circumstances, and how people are completely rational.
Definitely, that is one of the things that we see now, because it is like a black box in which we have used like cultural black box, which actually can be explained by many other things. That, as you very well said, you don't have to assume that everybody else is an idiot, but to understand what is going on. One of the things that we did interviews here in Bergen and different migrant groups, and we asked them, when the pandemic came, what was your first association with something you have lived previously? And among others, it was people from Poland that have the lowest vaccination rates here in Norway and many other places. And their answer was they thought about Chernobyl. And they began to take I don't know the English name, but what you took then there. And it was sold out in the pharmacies in Norway. They could not understand why. And the reason was this association. But what happened in Chernobyl was no clear message. The authorities try to push down everything, so they mistrust. And it's taken out now. So if you don't understand everything that's going on there, and you talk about culture, it's about past experiences, right? So all these things have to be managed. I still open up for questions from here. I don't see we have any questions from the audience out there yet. So I will just keep this issue, because you talked about this no having data. And in Norway and many other countries, I'm not a lawyer, but many times I've met this, that we cannot register because it might be stigmatizing, or it might be a bad thing for migrants to have data, because then you can say different things or act in a way. But now we see that without data, as you said, you cannot have any action either. And even if you have some action, you cannot measure what action is, what kind of effect you have. So from a legal point of view, what could be done about these issues?
Well, I'm going to use myself as an example. So I was a little bit impatient about getting the second vaccine. So during my vacation, I was able to have it in Berlin. came back and sent it in, and it took the doctor 3 hours to convert this into Norwegian vaccine passport. And I've been very skeptical about vaccine passports, but it's pretty clear that something quite radical is happening with European digital health infrastructure across borders. So in terms of a nation or a union building project, I mean, this is a terrible pandemic, but it's doing a lot for the union. And so we see supranational structures work in quite a different way than they have in the past. And so where does individual data fit into this, right? How can we do this? And you know, the road to national health registries is littered with disasters, including the Norwegian one. And you know, it's gold for consultants. So any of you students out there, if you're unemployed afterwards, just go for health consultancies and try to make a national health register. You can become a millionaire. I mean, it's very difficult to do these enormous projects, right? You can't sort of take this super perfect project and dump it in Peru and hope it's going to work, because it's not. But it's pretty clear that this is an ongoing thing we need to think about, right? So it doesn't really help if I can convert my German data to Norway if the basic structures aren't around. And then there's a trade-off, right? Because very often I get asked, do you want to save lives or do you want to have data protection? And that shouldn't be the tension, but we need to keep working in that dilemma.
Camila, you are in a very different context where you don't even have numbers for the population in Peru for many things. So it's not a Norwegian registered context, but do you see any kind of movement in that direction, or any kind of at least acknowledging that this should have been something useful and how to manage to take a step ahead in that direction?
I think that what the pandemic has unveiled a lot of things that we have been screaming here to say that the health information system was cracked in the country, and that we didn't have that, and the pandemic just showed that. So there has been more. I think that the authorities has been more aware of that, and they know that this. I think that there is a recognition that this is a problem. We need some kind of national statistics that we can trust. And I think that has been important. We, as a country, we make an effort to try to know how many people die from COVID, and this has been a national effort, and that is also the reason why we are in the statistics so bad, because we have made the effort to say to check the cases, to check all the registers of people that have been dying in the last year, and to check how many of them have been COVID and were not registered as COVID. And so I think there is more sensitiveness around the need to improve the information system, and also to improve the information system regarding welfare. The capacity of the state to provide this economic support for the family has been super weak. They were just not able to give money for the people that didn't have the residence. This is the poorest people. So the poorest people living in the slums in Lima, for example, that were making these pots, sharing pots to eat, and that they were not receiving the money. And people in my neighborhood, they were receiving the money. So that doesn't have any sense. And it's also because the system is too rigid and doesn't allow and because the state doesn't want to provide to anyone that is going to take advantage of that, and that shows that this has been just the wrong decision and have caused a lot of life and pain for the people that have not been receiving the money when they needed to eat, because it has been really tough here for many people.
I think the issue with mortality statistics is an important one. And you know, I think there has been this sort of routine exercise over the past year of seeing mortality statistics and saying, but oh, these children had underlying health challenges. So my child or my parents or me, I'm not in that group, right? But how do you communicate those different things, right? How do you compare the livelihoods of populations? How do you use or avoid to use fear, for example, to make people do certain things or avoid doing others? And I think we're going to discuss this for a very long time. one thing is the sort of direct impact of the pandemic, but the distributive effect on people's mental health, for example. You know, if after having 2 vaccines, you're still not safe from Delta as a 75-year-old male, what are you going to do? Are you going to stick to the sofa? So I mean, but mortality statistics and how we communicate them, and also how we look at them afterwards. So if one country has diligently registered everything and another country has registered very little, you know, they are going to come across as very different cases and with very different politics following that. But it's a very interesting topic, and for anyone writing your master's degree, it's a very interesting topic.
And I would like
Camila. Yes.
to think of the vaccination that Kristin was telling. Here, the wealthier went to the United States in April, May, went to vaccinate, no? And but we cannot get that information from the United States. So these people that have already vaccinated in the United States, they are coming here and they are getting also the vaccination here, because they want to be more protected than the rest. And okay, there is no solidarity and nothing, but it's because we also cannot exchange the information with the United States. There has not been any kind of agreement for that. And yeah, so we will see how this is going to work at the end. But a lot of people is just receiving 4 shots of the vaccines or 3 shots, and these are the wealthy.
We do have a question for you, Camila. There's somebody who's asking, do you think the situation in Peru is going to change now that you have a new government? And how do you think this can affect migrants specifically? You might give us a short orientation about the new government. There's not everybody that has the last news on the governmental situation in Peru.
Yeah.
Sure.
Okay, we have the elections, national elections in April, that with our second voting day on June to decide between two candidates. And the migration has been an issue during the whole campaign, and has not been nice, has been against the migration, and there has been a political campaign that has been characterized by really conservative thinking in almost all the candidates. Yeah, as a way, because I mean the country is in the sense of economic crisis coming from this pandemic, that we has been in lockdown and that, so has been really asking for authoritarian measures to control criminality and that kind of stuff. And Venezuelan has been targeted through the whole political campaign by almost all the candidates that were more conservative, and it's conservative on the what you can call the left and the right. No? So the new government is the one that Pedro Castillo is supposed. He presents himself as a left wing, but really in the old terms of the left wing. And his discourse and the discourse of some people of his political party has been against Venezuelans, and the Venezuelan population has been super afraid of this. Till now, nothing has happened, especially to the situation of the Venezuelans in Peru. I am afraid that nothing will going to change, and this is not good, because we need to make something to improve the situation of the population. But I think they are going to continue to be just invisible for most of the government programs, and that is going to be the status, no? So this has been the situation since they arrived, and there has not been really any politician that has been fighting and taking this as a serious problem. And in this situation that the whole country is in a crisis, I think the political is going to be too costly for the politicians to take this. So no one is doing that. And I think that is super problematic.
Thank you. We are talking a little bit about xenophobia, and you were saying that they went from heroes in May, or when they were taking these dead bodies out, to be like blamed because of the situation. And this happens as well with refugees very often, even though we have a lot of evidence about refugees not being an issue in terms of infections. The first thing most people think about refugees when they come to a new country is that they're going to take with them infections, which we do know no, it's not necessarily the case. And then this of having the vaccination is both because of the protection of health, but also in terms of being able to do things that have nothing to do with health. But so how do you think this link between health and politics and discrimination is lifted up during the pandemic, and how can we work with that so that it's not so next time we have a pandemic?
It's a difficult question, right? But you're right about the double function of sort of health and sanitizing a population, so it sort of has the stamp of being safe. Next time we have a pandemic, that's pretty depressing to think about.
We will have a new pandemic. We have
I think most of the things we have learned about this pandemic relates to domestic responses, such as the lockdown, for example, or measures, effective measures, and when you do it. In Norway, we have this terrible concept called importsmitte, which is probably the worst part of the Norwegian COVID-19 vocabulary, because it means that we're importing, and it has certain connotations. It means people from the Baltics or Poles, essentially. And coupled with information that they don't want to get vaccinated, this is not such a great thing, right? So how do you work on this? I have no answer, but I just think that, we thought this was going to be over in 6 months, in a year, but now we realize that even in countries that can emerge from this relatively intact, everything has changed. And that was just a lot of not good answers to your question. I'm sorry.
Well, we figured, I said that from the very beginning, this is too complex, but it's more like lift up the idea. So when I ask these questions, I don't expect to have
but I do think that in a certain way, the US vaccine hesitancy and the spectacle of all the Sandviks who migrated to the US and started voting for Trump, now refusing to take the vaccines. It's perhaps helpful to think about if you want to blame somebody who's Rohingya or someone from Colombia or somebody from Zimbabwe. The fact that this happens in pockets across the world, and it's a global challenge.
You're completely right. As far as I know, the best predictor for a person living in the States, if he or she is going to take the vaccine, is which party he or she has this given the vote to. So it's kind of linked to politics in that way too. Camila, do you have any kind of reflections about this stigmatizing refugees as the source of infection, politics being mixed up, as you will explain now in regards to the elections time? Do you have any ideas how we could improve this situation for the future?
Well, I think that, at least in the case of some of these Latin American countries, that we have been used to send people and not to receive so many people, that has been a big challenge, no? And it has been a situation in Colombia, in Ecuador and Peru, but I think that we have been lacking here of a more open conversation on what this means, no? And I say at the beginning, when they started lockdown and that, there were some Venezuelans super afraid of in the need to go outside to get some job, and they were targeted by the police, for example. No? And that was a mix of to show them as the ones that are irresponsible, no, but that come from the past of all this xenophobia that was already in there, So, but I think that has been we have failed as a society to be able to speak about this issue more openly in the case of the migrants.
I mean, I you might have seen this by now, but I'm fairly skeptical about the trade-offs that have been made between the rule of law and COVID-19 interventions. So we have locked down the world because it's threatening the global north and the global east. And for a lot of populations, this rates initially fairly low on the scale of life-threatening events. But because the implications of interventions have been so severe, as we learned yesterday, 22 million kids locked out of school in Uganda. But this is really a global justice issue, and I would like a more critical discussion about how we have dealt with this in the West and how everyone else has to pay. Mm-hmm. I mean, I'm completely acknowledging the devastating impact on the pandemic of itself, but certainly it's been more devastating what we've done to deal with it, to protect ourselves.
Food insecurity has increased, poverty has increased. There's a lot of issues that we should have a look at afterwards, not only what is happening in each country, as you said.
But I think sort of, once you say this, once you start protesting against apps and vaccination passports and quarantine hotels and lockdowns, you end up in a political camp where you might or might not feel very at home. So this has been interesting, right? So try to be critical is very often to be seen as unpatriotic.
Yeah. Sure.
Or even as hostile against science, right? So it's interesting to try to think critically about this together, because
it's again about complexity and humility, that you don't alone, one discipline at a time does not have all the answers. A couple of weeks ago, it came up a paper from Sweden, Denmark, and Norway. They have counted the effect of the different strategies in Sweden and Denmark and Norway, and they come up with the numbers. If we in Norway and Denmark have the same politics that they have had in Sweden, the rates of hospitalizations and deaths have risen like 300% or something like that. And it might be true, but still, if we only take that into account and not all the bigger side effects that you said, we are only seeing partial picture from one perspective. So those are interesting issues. I can't see any more questions. I think we can just touch upon one last theme at the end, because one of the things that I've been very, very working a little bit about during the pandemic is that of the user involvement. In the few places where there was something that was happening for migrants, it was only after sometimes that it was with migrants for migrants. And in Norway, what happened is that when the government realized that the information was not getting there, so they outsourced this work to the NGOs and migrant communities. And this has been seen as a success in a way, which is it, because you make some bridges, but on the other side, they professionalized something that you are giving professionally to the rest of the population. You could never accept that persons without a health background could give information about health for the Norwegian population. That's what we have been doing with migrants here, right? So it's again a trade-off, but I'm very much about thinking about this, including user involvement in all this future work, including refugees, including Venezuelans. Is there anything that points out about any lessons learned during this pandemic for the future? Camila, something which is happening together with people from Venezuela to improve the situation there?
I will come back to the point of the cultural barrier. No, if we portray this as a cultural barrier, then we are not, the health system is not open to different views or different mechanisms. So it's more like the users, and that when they are called, is just to listen why the health professionals are going to tell to them. And there has been also a lot of conflicts within the health professionals. So the medical doctor has to do this and nurses that, and you cannot put you cannot do what the medical doctor has to do, and it's difficult because we don't have that amount of resources. Not with migrants, but for example, with indigenous population, they have their own network, they have the people that they trust, they have their own understanding of the disease and how to treat the disease and how to control the things. but the state has been unable and not interested to try to understand that and to involve and to take that and to allow in a way the indigenous communities to make what they know and to try to and that will also make easier the vaccination, because around indigenous population there is a lot of rejection historically against vaccines, and now is the higher rejection there that we know at least. So I don't see that the COVID pandemic is bringing nothing new in that sense, because it's there has not been space for debate with this huge crisis. We have been accepting the things in a really precarious health system. So we knew that this was going to be awful, and we need to gain time, and we were supporting some of the measures in a way that to say, okay, we have to stop. But for example, we are still here with the schools closed since March 2020. So kids have not going back to the school. And there is no reflection on vulnerabilities or inequalities, no? So the people that have more money is able to put the schools with private schools with all the conditions, and not the poorest. And I think that is at the end the debate, who have more money and these are the ones that went to the United States to vaccine. So it's an awful situation, and I don't see that we are bringing different views or understanding of the health system and creating many opportunities. It's just more like in an emergency setting, and you just react still in this, at least in Peru.
Did I listen correctly that the schools are still closed there?
Yeah.
Okay. Any kind of user involvement in the field you were talking about, or?
I just want to say that listening to Camila, you almost feel stupid being somebody who's looked at a Norwegian situation. But in a sense, with the pandemic, we've been stuck here, and you work on your own country when that's what you were able to do. You know what? So I've been working also a lot on the Nordic response, and in Sweden they had this slogan called "Folkvett," which translates into individual sensibility and rationality. In Denmark, it was something sind, sort of this loyalty or duty to society. In Norway, it was famously dugnad. Come on, let's do it together for free, from the Norse dugnader. And this isn't unprecedented. If you looked at refugee crisis, we all remember Refugees Welcome Norway. I read an interesting master thesis where one of the headlines is used, "System collapse, a call for me." So I think the willingness to do civic engagement. I mean, it's pretty American, but I don't consider it particularly problematic. I think we need to improve, and clearly lots of Norwegian minority groups have a large group of health professionals in their core, and it will be more and more and more. So, but I think the dugnad business is it's not specific to the migrant communities during COVID-19. So that's not specifically an issue, I think.
No, in a way, no. And it's funny that you talk about this dugnad, because in those interviews that I was talking about, we asked them, what do you think about this dugnad? And many people just didn't know what dugnad was, which makes it very difficult to attach to that kind of presentation. And there was a lot of misinterpretations, because dugnad was something that you go out and do together with others, and now we cannot go out. So it was it was very complex and not well understood. So in itself, it was a barrier to present this when it comes to migrants as a dugnad, because not all migrants understand what a dugnad is. And yes, there's a lot of differences. And as you say, study in Norway might be looked at a luxus situation, but we can learn from here as well. And I think working with migrants, for migrants, is the best way forward to both parts of society, personally, to improve the situation for everybody. Because if you have a good situation for the most vulnerable ones, you have a good situation for everybody, and it applies to Peru as well. But
if I can just raise one issue when we talk about the vulnerable ones, right? So the vulnerable ones are not a Somali Norwegian woman aged 28.
No.
I think what we saw during the pandemic, that not only the medically vulnerable, but the socially ones are maybe also retired people or people who are older. And so there is an age issue here that we haven't really grappled with yet. And I think that's sort of, you asked about the next pandemic, right? Sort of the next pandemic will be highly digitized in its responses. And presumably the people who are me now will still know how to use digital technologies when I'm old. But I think there's just a new cluster of questions that we need to ask and learning from this one.
There are lots of questions, and we might replicate what we did in the past. The most of the countries that did have something prepared for the pandemics were prepared for the influence, for the flu. And that was a mistake, because this was not the flu. So we have to be careful that we don't have the next, that we are not prepared for COVID, because it might be something different. So there's lots to learn, definitely. I just open up for one more time if there's any question for the public. Is there anything, Camila? Yes, there was a question there. Please. Yeah, we might. Come here and say who you are.
Yeah, excellent.
Let's take the floor.
Thank you. Yeah, I'm from Nepal and I have been in Norway since 2 years. And I am here as a student, and most of the post or any articles I am reading is concerned to students who wants to study in Norway, Canada, USA, Australia, like other countries. And we are positive for receiving vaccines in Nepal. We have Moderna, we have Johnson & Johnson, and also so many of them are getting some Chinese vaccine called Verocell or some Indian something. And like students are getting vaccines so that they can cross the border, be in the other country and be accepted there. But recently I have been seeing that, for example, Canada is accepting only Moderna and Pfizer or something. The vaccine Verocell that we can easily get in Nepal are not being accepted there. So I'm just wondering, like, if not only about getting vaccine, but we are also creating inequalities or inaccessibility in terms of what kind of vaccines we are getting. So I just wanted to hear if we have any thoughts about it.
I think it's a much welcome practical example of the type of sort of vaccine wars that are going on, with American, European, Chinese, Russian actors being involved in sort of aggressively pushing information about others' vaccines. So I mean, this is a very sort of heated field of disinformation, but clearly with practical implications for students, for example. I think this is, one of the things that it's easy to overlook, right? But you have a vaccine and suddenly somebody decides that it's not good enough to enter a country. That was very difficult to foresee. And this is about, big politics. Huh? But I have to say, it's very interesting to see how this travels in social media and misinformation from everyone, not only Russian and Chinese actors. But I think telling your story, maybe, you guys should write a blog post about this from, what does it look like from a student perspective? What are the practical obstacles here?
Because it's so many students are just eager to go out and study, because we have been kept on hold for at least 2 years now, and we would be done with masters. I'm glad that I'm in Norway. I'm done with the masters. And but there are so many students still waiting to finish their studies. And this type of vaccines they are getting is I see it as a new barrier to their educational journey or anything.
Thank you.
Thank you very much. This was a very nice example on how the complexity and the link between health and politics and law and every other field is necessary to study together. So I want to thank you, Kristin, and thank you, Camila, for being with us today. Thank you to all of you being here and those of you who have followed us digitally. And we will come back soon. Bye.
Thank you.
Thank you. Bye. Take care.